Hey everybody, this is Dr. Ben Pearl with FitFoot U. So today we're going to have a plastics edition, a plastic surgery edition, and I'm pleased to have, I guess, a fellow IU alum, as it turns out. Brian Poindexter, I guess in the clinic he's known as Dr. Brian Poindexter, Dr. P. He's going to fill us in on with the podiatry population that I have watching this podcast, some of the things about flaps that we might want to consider, but then also give an overview to some common things for the lay people about plastic surgery and maybe some things that he's had for probably a over 3 decade career doing plastics. So welcome to the podcast, Dr. P.
Well, thank you very much. Thanks for having me. Actually, my brother is Brian Poindexter. I'm Byron.
Okay.
Uh,
That was
so,
a that was what we call a familiarity with the name that happened under the recording. But I'm glad you corrected me. Uh,
well, I'm just saying that because he might become famous after this, and he just needs to be
that's right.
prepared.
That's right. That's
So
right. Well,
he's
and
also back in Indiana. So
yep, yep.
anybody that's
Well,
tuned in and knows Brian Poindexter, we're a little bit different. He's a lawyer. He's actually a judge. So don't judge me, and just hopefully I can come up with something clever to say today.
you already have. So I will share one thing because of the fact that we were both, I guess, crossed over. I might have been a senior or at least a junior when you were entering IU. I was 87. I padded my curriculum with some things that I had a passion about, which I still am passionate about, of the crossover sports medicine as a vehicle or sports as a vehicle for folks that are trying to mainstream, whether it be physical challenges or mental challenges. And I think you deal more with psychological challenges, which is why your dual degree is very interesting, that you had both the chemistry and the psychology degree. So before we launch too far into the technical, I'm going to ask you some things about that choice and how it's applied to your career, because we're in ever more challenging times with body identification, dysmorphia, all that stuff. We just recently had that Demi Moore movie, which was horrific, but very, I guess it had a very interesting message as well. One quick thing I wanted to share at IU. I mean, so I had a lot of electives and a lot of psychology and learned a lot about people and still am learning each day with my patients as there's new scenarios post-pandemic that come all the time. One thing that I think was interesting for me is that I had the opportunity to take some coursework that was done with teaching TAs that were at IU. One was in my chemistry class, and one was in my anatomy class. And one of the things that you'll get a laugh out of is that when I did my chemistry lab, the requisite was that you would get an accurate accounting of the supernatant as you distilled it and then did the subfiltrate, blah, blah, blah. And I was looking around the room in the lab, and everybody had these beautiful crystals. And then there were like one or two of us, like me, that had this big gray glop in our filter. So I had to introduce the fudge factor. I have to sort of own up to that now that that's kind of how but what I liked about this course was that the TA allowed us bonus points for getting David Bowie's alter ego, which I knew was Ziggy Stardust. So I think that's part of what helped me maybe get my B minus in chemistry lab. Anyway, on to you, and maybe you can
Well,
you can either share a IU story, or we can get right to some of the stuff that we talked to at the onset.
Well, I will tie into that in a couple ways. One, we have three miniature horses, and two are they're they're all rescues, but the last ones came from a rescue organization, and they came with the names Ziggy and Bowie. Um,
How
so
how crazy is that?
so we completed the names, and we now have David Bowie and Ziggy Barndust.
That's
So
awesome. I
So
think the
yeah, so
stars have aligned on this podcast
yeah.
already.
So
All
that's that connection. And then to go back to the chemistry and the psychology. So I started off, I was going to do biochem. Really, I was always going to go to medical school, it seemed. I didn't have really another plan. And so I was doing a lot of the chemistry work like you need to. And I was taking psychology for my minor. And um, all the really, well, there were a lot of really pretty girls in psychology. So I just kept taking psychology classes. And I eventually just got enough to actually have another major in that. And so since I had a double major, I was like, okay. I can just go with these two, and I don't have to do the biochem. So that was the completion of that loop of stuff.
Uh-huh. Did you have to do summer coursework to get all the requisites, or you were able to do it in clean in the 4 years?
So I did biochem or not biochem. I did organic chemistry 2 and organic lab in the summer. Um, Partially because I needed to get some stuff in, and also it was supposed to be easier in the summer. And I've received two B's in my life, and they were both in organic. So that was the probably the right route for me as opposed to toughing it out. I think one was organic lab. So I think those were my two B's.
We
Uh,
might have
to
rotated through the same professor. I remember mine had a beard, super nice guy, was always made himself available. We didn't have to go to the TAs if we had questions. So yeah, I mean, I guess the take home point for anybody listening in is it's a good idea tactically when you're in a pre-med curriculum to take a look at your course load. And I did the same, with some of my courses to spread it out a little bit if you have the ability to do so.
Mhm.
Let's get into, I guess, how psychology, how that has helped you through your career. I'm sure so much so with your field in particular.
Yeah, I think there's a saying. I don't know that our originating partner actually originated it. Harvey Austin, who was in practice from the late 1960s on for the Austin Weston Center, but he would say that plastic surgeons are psychologists with a 10-cent blade. And 10 cents probably being the price of a blade back at that time. But there is a ton to it. And from the extremes where you could have body dysmorphic type stuff to the overall implications of what it means and changes for people. And it can be very empowering if you let it be. And the we actually had um, a scientist from Penn State or the University of Pennsylvania come and spend some time with us uh, probably 2 decades ago studying patients. And she was doing some things and studying the language of healing. And there's actually a healing language, not just in our culture, but all cultures. And to boil it down really quickly within plastic surgery is that there's a narrative of healing that all cultures tell. It'll be different in African medicine versus Western medicine and Eastern medicine, but there's this healing narrative. Uh, and part of our narrative has to do with medications, but also people will feel it's like, you know what, if I can change this thing, if I can change that, then I can be different. And you can actually have that narrative take place and work. And it's, some people might say it's the emperor's new clothes, or it's the a placebo effect of it, but it is a narrative that allows them to make a change. And we see that. We see older women who say that they feel like they've disappeared. Nobody looks at them anymore. They're invisible when they go to the store, X, Y, and Z. And when they've made some changes, they're rejuvenated. They look younger, and people start looking at them again. Now they're more engaged in society. There's a really interesting overlap between psychology and the surgical aspect in both normal and then also in that kind of shift to slightly abnormal stuff. So it's been a very interesting thing to do.
Yeah, I mean, I think I don't know if that's part of Maslow's hierarchy of needs, but certainly affirmation, validation. I mean, to the extent that how do you deal with the other extreme when we're sometimes too much so? where everything has become so surface in our society.
Yeah, if we can identify that ahead of time, it's useful for us because you start to see that, and you will see a patient that you're not going to be able to make a positive difference for, and then you still want to be able to discuss things with them that can let them have a positive outcome. You might identify them and say, this is not a surgical or a non-surgical candidate. They don't need plastic surgery. It's not going to be appropriate for them, but there's still a way to perhaps interact with them that is positive and encouraging, as opposed to just like, okay, you don't have any problems, get out of here, and then you're really not dealing with the situation. So um, yeah, I hope that covers.
Yeah. Let's move on to something a little closer to what I do. And I used to do more of. We have a wound care center at Virginia Hospital Center. So the flow of wounds seems to go towards that. But at one point in my career, I was doing quite a few wounds, and I just had recently heel osteomyelitis that could have required a flap. It's sort of in the in-between stages of being care at a sniff unit. And I had actually referred them to a plastic surgeon I trust a lot, Chris Attinger, and then he's got his cohort, John Steinberg, who's a podiatrist. That I don't think that has officially happened yet, but it's sort of in the wings. And just to give you sort of a thumbnail of things that a lot of what podiatry is doing, we're doing a lot of skin substitutes that obviously don't require the flaps. We're doing a lot of vac, which I'm sure you do as well in certain situations, although that might be more towards the earlier part of your career when you were doing more all-around stuff. And then in particular, now podiatry is looking at crossing over and a little bit more into the aesthetic field with something called liposana, which I just started to put on my website as an offering for plantar fat degenerative changes that we wouldn't necessarily want to do an elevational osteotomy for. So maybe you can let's start with, I guess, what's very classic plastic surgery with flaps and different, I guess, quips, pearls, tips, and things to avoid that you could, spit out.
Okay. We'll just start with basically the idea of a wound, an open area on the foot. As plastic surgeons, we try to think from simple to complex. And then also, I was taught in general surgery to think dirty. And that's meaning like what's the worst thing that could happen, in any type of situation. So you're always balancing those types of things. You want to be simple and you want to have few complications. So if you can get something to heal on its own, secondary intention, tertiary intention, if you can get it to take care of itself with a wound vac or with local wound care, and get a stable type of wound, then that's fantastic. So that's where you would talk about the more complex things now, like a wound vac. And for if there's non-medical people looking at this, that's a vacuum-assisted wound dressing that puts a negative pressure to the area, perhaps draws more blood vessels into it. Neovascularization would be a word that we would use medically. And so that can assist local care, or you could just have dressing changes where you're just putting a gauze on and taking it off, on and off, on and off. So that will allow us to get some things closed. Problems with the foot is that it's dependent, it's down. It will maintain swelling much longer. There's edema. It's difficult to get that out. The blood supply is not good. And as we get older and have had injuries, it gets even worse. And the people that typically have problems down there probably have other problems in their bodies. They have decreased blood flow in, decreased blood flow out. They have venous stasis. They probably have atherosclerosis. They have maybe diabetes. And so sometimes the simple things don't start to work there. And then you work your way up in complexity. And if you can't get it just to close locally on its own, then you have to get tissue from someplace else. One of the simplest ways to do that is a skin graft, to take skin from one part of the body and move it over to the other. That can work probably okay on the top part of the foot, on the dorsal surface, because it's not going to be weight bearing. It's not going to get rubbed. skin grafts to the bottom of the foot maybe can take it their full thickness and small in an area. But you have to get really thick skin and try to match it. Maybe you can get it from the other foot. Maybe you can get it from someplace else, the back, if you need thick skin. But skin grafting to the foot, not fantastic. If we go way back in history, and this is, I've got like one experience with this, which was really very cool in my residency, but you would do cross leg flaps, which means you would go to the other leg, lift a flap of tissue, and then sew it. You wouldn't completely remove it. You would remove it like 2/3 of the way and lift it up, but it's still attached to the other leg. And then you would sew the foot across or to the other opposite leg, or almost the person sits cross-legged for weeks, a couple weeks as this thing heals, and then you can divide it from the first leg. So flaps like that were done very early in plastic surgery, and we learned we could move them from one leg to the other. We could walk it up the body. Very, very cool stuff. Those were walking flaps. So we did that with an infant in a NICU down in Florida many decades ago that had an amputation of the lower leg after a vascular injury.
Can I ask,
And
can
we
I
were,
just interject? How do
yeah.
you keep the vessel, the sort of the umbilical on the spacesuit, I'm thinking, as you're floating out in space, viable? And
So when you attach it from one side to the other, so you've lifted the flap from one leg, uh, sewn it to the other leg. The legs are now sewn together. You will get vascularization into that new flap from the edges and the base of the other wound. That's the way things start to grow. So blood vessels grow into it from the recipient leg. And once you get enough of those over a couple weeks, that's when you can divide that and get rid of the original blood supply.
got it. How much
So that,
how much actual, if I'm imagining then, so there's very little exposed vessel neurovascular structure. It's all underneath the surface. It's okay.
yeah.
Got it.
And you don't have to have that. That can be a random flap. So it does not actually have to have a a particular named vessel. So it's raised and it's based randomly at the base, a flap length of 3:1, something like that. And then you can just keep a random flap alive on a 3 times the length of 1 time width, with no particular vessel. The subdermal plexus and things like that will keep it alive. And so that just kind of regenerates on the other side. So that's the kind of a simple and way old time way of covering things on the opposite limb. There was a guy named Tagliacozzi, an Italian, who would reconstruct a nose after syphilis from the skin on
Mhm,
the
mhm.
arm. So this would be a Tagliacozzi flap. So they would lift it up off the arm,
Wow.
sew it across the nose. You walk around
Wow.
like this and this is, I'm going to miss the actual century, but we're talking 13, 1400, something like that. I
Wow.
mean, long time ago. So anyway, that's old plastic surgery. Then more modern to the lower extremity, you'd look at a local type of flap, like a sural flap based upon the sural artery that you can rotate from the same leg, and you can move that down around, and you can keep some of the vasculature, and you can get a decent sized flap from that. And then you progress up to not local flaps, but distant flaps, free flaps, taking a muscle or taking just some thicker tissue from another part of the body, and then attaching those vessels, the donor and recipient artery and vein, to those of the flap under a microscope, and then you can get coverage with that. So that would be the kind of the gamut of things that we would have done in our history to get lower extremity coverage.
Would the sural flap be something that might be the flap of choice where you have the avascular zone right by the Achilles that might break down from posterior abrasion in the shoe or otherwise?
Yeah, that's you're gonna be able to turn it and rotate it and get it into that area. You're probably not gonna reach, further. You can get a little bit further around, but it's not gonna get you distant. But it's great for that region, from my experience. Again, it's been ways past, but yeah, that's where we would have used it.
And because you're so, I guess, versatile with the amount of choices you can have with plastics, do plastic surgeons in general, unless they're in a wound care clinic where they're seeing diabetic foot wounds and venous insufficiency wounds all day, tend not to use things like the fish graft and the stuff from placenta and umbilical and all the other choices that we have, the bovine and pig stuff. What is the sort of the consensus on what plastic surgeons like to use that may do some wounds, but it's not the majority of what they do in terms of those other options?
Yeah, I think that you probably get the people that um, plastic surgery has now become so specialized. Like I'm now doing, exclusively cosmetic, that it's going to be the wound care guys that there are going to be working in a wound care center, and they're going to have all those different things in their armamentarium. And I wouldn't be able to speak to, what they're choosing to use, but
Gotcha.
um, average Joe plastic surgeon in general, speaking as one of those guys, we're going to again tend to think simple. And we're going to tend to think of things that we have a history with, and you're probably if we're probably going to jump past a lot of biologics and bovine and say, okay, if you're going to be using this, we'd rather use something that is more permanent and comes from the person. So we're more likely to take, a flap and rotate it and move it and just get coverage now, as opposed to trying to just kind of eke it along with that with the local care.
Understood. Let's jump now to what you traditionally do more of right now, and aesthetic plastic surgery. I understand we've come a long way, even in the last 10 years, from the traditional facelift. We've got the adjunct lasers. I think the one regenerative area that it seems that you guys do is, and I know this is very popular with the needling, is exosomes, which is very controversial in our field because I think people overstated, oh, you're gonna get rid of all these autoimmune diseases with exosomes and the inhalational stuff. And there may, in fact, be some benefit to some of the various ways that exosomes are administered. However, I think also the public at large needs to sort of know that some of the claims are a little wild and speculative. That is only one small little extra credit thing that you guys do. So maybe we start with some of the basic changes that you've seen over the last decade that have transformed the field.
Yeah, and it's interesting as you say that. I think that there's a lot of things that get hype as being the new types of things,
Change.
whether it's like it's exosomes or PRP or PRF, or the growth factors and the stem cells and whatever that people are doing. And we don't see big leaps in those areas. We see lots of uses of them. We see lots of things to talk about the possibilities of them. The bread and butter of plastic surgery, which is kind of make an incision, elevate tissue, tighten tissue, get rid of excess tissue, that remains where the 90% of the results come from. They come from traditional plastic surgery procedures. Now, whether you have finesse in doing them in certain ways, that has advanced. We do tummy tucks without drains. Now, I've been doing it that way for 28 years. There's still a lot of plastic surgeons, the majority who do use drains to get fluid out of that potential space. It's not necessary if you use quilting sutures and do some other things. There's different techniques for maybe rearranging some of the deeper tissues. I think advances that we've seen that are really positive are more in things like pain control, bleeding, things like that. So the pain control we use, and this actually, I think, probably gained its FDA clearance in podiatry, would be things like Exparel, or there's a new long-acting anesthetic with bupivacaine in it, another kind of injectable that's escaping me right now. Oh, Zinrelief or Zinrelief, that's used for incisional type stuff. But these are things that will give perhaps 72 hours worth of local anesthetic block. And that is using and like a vesicle to maintain. So that is where technology is saying, okay, we can take this drug, put it inside a little vesicle, and let it release over 72 hours. I don't think what we've seen successful very much, besides hype, is let's put growth factors inside this little lipid vesicle and then inject that underneath the skin and let that do something dramatic.
Hmm.
So they do a little bit, they don't do a lot. I've had exosome and treatments to try and get rid of like a thinning spot in the back, and I've had PRP in that area, my own blood's been down, not seeing really any difference, anything notable. It's like, oh yeah, that's great. It's like, I may have done something, but it's like little stuff.
Hmm.
Other technologies, radio frequency things that we have to stimulate college and do things, they do a little bit. They do about 20% of what you'd really want them to do. They do stimulate some college and they get some growth, they get some tightening. But they're not changing the game
Hmm.
ultimately. Lasers have improved since the time I was in medical school. A big surge in what lasers have been able to treat as far as pigmentation, um, and being dialed in to treat tattoos or to treat now, 40 years ago, you weren't doing laser hair removal, but now it's just very, very simple for people
You
to
like
do
them for
things like
scars?
that.
Do you?
It's okay. The
Yeah.
some of the Fraxel CO2s may be okay for some scars, creating little zones of injury.
The
We use
1064 YAGs can seem to make the tissue a little more mobile. I'm not sure for aesthetic pleasing that people don't run out of gas with the number of treatments you seem to need with the 1064 YAG. Like I have a cutaneogenesis myself that has a scar protocol in it. Any thoughts on that particular laser, or do you not know the platform enough to be able to comment on that particular
yeah
one?
yeah we don't. It's not one of the ones that we utilize. So that we probably cover that wavelength a little bit with a little bit of a different laser, but may not have the same pulse length and the energy that you'd be utilizing, because I think we might utilize that for some reds and and some discoloration that people get. We use things that are absorbed by water. The erbium laser, it's like a CO2 laser. We have a fractionated CO2 laser absorbed by water. Those are for skin tightening because you can use to ablate and remove tissue with that. Um, so we do a nice job on fine lines and wrinkles and things with that, with those that 2 decades ago, 3 decades ago would have utilized chemical peels to try and get the skin burn. A laser gets to control the skin burn a little bit better, but that's where we're using those modalities these days.
And wrapping up this
One thing,
section. Oh, go
oh,
ahead.
I was going to say,
You had
just
another
talking
thought.
about, well, and talking about scars, and I think you may have been going to go there. But as far as treatments, like if hypertrophic scars, keloiding type scars, and when we're faced with those, we do a lot of injection of those. And that has changed definitely in the last 10 years. That before we would just inject steroids and steroid. That's all we had when I was in my residency and for first starting out. Kenalog into that, then you can get some uh, atrophic scars. You can get some problems. Um, if it was really terrible, we would use radiation therapy. So you can radiate keloids, or you can cut out a keloid, sew it together, and immediately radiate the area with an old-fashioned laser, old-fashioned radiation, get superficial treatment, and not have a keloid come back. But 5-fluorouracil, FU, to be is really the key for us now. We use that in conjunction with Kinalog, basically 3 to 1. I think is the number that we use. So more FU than Kinalog, some local anesthetic, and inject that, and that's much more successful in treating the hypertrophic and keloid scars. And for people in medicine may say, okay, that 5-FU sounds familiar. It's an anti-metabolite. It's basically a cancer drug that we're utilizing for that, and have been for quite a while now, like the past 10 years, with pretty good success.
Yeah, we use it in the podiatry space off-label, I want to say. So it's not our first choice in the form of Efudex for warts. So it's got some antiviral activity as a modulator as well. Well, I'll probably be asking you like trading recipes after the podcast. Certainly don't want people cooking up stuff in their kitchen with 5 floor ears. So
Yeah.
that would probably not do either of us a service. So I wanted to kind of wrap up now more of, I guess, some of the more common and more sort of pop culture aspects about the whole field of plastic surgery. How is it, Dr. P, that we have, celebrities that have beyond our wildest dreams? I mean, you're not doing bad as a plastic surgeon. I saw you got a real nice plot and a nice barn that some people would consider a house. But like, people like Kenny Rogers and Michael Jackson. I mean, for those that haven't seen this result, it looks like he had a double something or other that went awry, some eyebrow lift. I don't know if they do an eyelid lift. How is it that this stuff happens? I mean, and I don't want to be one to cast stones. We all have made mistakes. But what's your sort of thought process in terms of that?
I think there's a couple things that go on. So a Michael Jackson would be a body dysmorphic type of issue, where somebody is just like more and more and more. So, and that can happen. You can see people. It's like that they just don't know when to say no. They don't see themselves correctly, and that can happen to someone who's famous as well, as somebody in the gen pop, just like us. So that will exist out there. Uh, the other, I think what people say is like these people have all the money in the world. They could go to anybody. How do they have this happen? Um, I think what happens, like in that Kenny Rogers case, God rest his soul, is that the face was feminized. So instead of doing the operation in a way that maintained masculine characteristics, you just did the same operation that you do in the female, in a woman. So the brows are over elevated. In men, they're supposed to be at the bone. Maybe they can be slightly lower. In women, they're supposed to be at the bone or above. And obviously, his are above. The cheeks were overfilled and lateralized and put into a feminine position. So it's like that would have been a really good kind of female facial rejuvenation, but it wasn't one for men. I did a talk at the national meeting probably 2 decades ago for a nursing group, about that, about cosmetic surgery in men, and looked at a variety of things like that, and looked at what make, you know, male faces attractive versus female faces attractive. And we're, you know what, I want to say we're pigs. We're not pigs, but we're allowed, in society to have, more wrinkles and lines and character and things like that. So, and it's appreciated in men. Um, uh, Unfortunately, it's not appreciated in women. And the best place in my practice could be kind of from a social standpoint is that people really were kind of like, okay, that's not important type stuff. We have other things to deal with, and that's superficial. Now I go back to what I started and said, what we do find is though we really make a difference for a lot of people. So if you can make a difference, that's what we're doing. But it would be great if people didn't want or need me overall. But I think with these people, we're seeing people that are just having too much, or they're just not having the right operations chosen for them. In Hollywood, also, there's such a drive for people to be young and look young and not necessarily just attractive. And like, well, young faces have this characteristic, the young faces have this characteristic. And so we're going to fill them up. We're going to plump the lips. We're going to do this. And it doing those things to an older face doesn't make it look good. It makes it look funny. And
Yeah.
so I think, what I'd like to see, and thankfully on the East Coast, we have a different kind of appeal, or a different kind of ideal aesthetic, is that I'm just helping people be more attractive. And I'm not trying to create, a 32-year-old face on a 62-year-old person. I just want people not to be able to tell how old they are at all. It's like, wow, they look good. I really don't care about how old they are. That would be the ideal.
Yeah. Well, as much as I hate to admit it, I have not had anything other than some temp stuff. I was at the airport and I was looking rather tired, and I got a couple wrinkles now. I've had more than a couple things happen in the last few weeks, but this young lady, she put the little Botox cream on, and I gotta tell you, I think I had a podcast or something where I needed a photo, and it was nice. No makeup, just had that little, that little plus for maybe, I don't know, 8 or 10 days before it even faded, that it was noticeable. So it's quite amazing. Although I will say, I am less self-conscious about the male balding pattern than I used to be. I mean, I'm lucky enough that I still have some hair, whereas, if you want to call it lucky. How is it that the Hollywood stars that might even start to look a little grizzled? Like I was just watching a Netflix series which was very good called Sirens, which had its own array of plastics, I'm sure, on it. That you have guys like Kevin Bacon, Tom Cruise. They'll have these kind of chiseled faces that are starting, and for Kevin Bacon, a lot of times, and to your point, people think it adds character to his roles, and yet they have these great heads of hair. Is that genetics? Is that something that we don't know about behind the scenes? What maybe you probably know the inside baseball on a lot of this stuff about how it is that they, remains as so youthful, which with hair is a major characteristic of what you see in the movies from the far shots.
Mhm. I'd say that probably like the Kevin Bacon, those examples, those are just people genetically, that we're blessed. You can go back to Footloose and look at his hair and probably predict that it was going to stick around for quite some time. Um, so, and genetically, when we get to hair and start thinking about it, and that's how hair transplants work when people get them, is that if you transplant hair, take it from one area, like the back of the head, and move it to a new area, it maintains the characteristics of the area from which it came. So it doesn't then just fall out because you put it into a new area. And so there could definitely be people that are utilizing transplants and things like that. And they have tremendous makeup artists and CGI and all kinds of good stuff that we don't get to have in our everyday life.
Yeah.
We could try some makeup, some camouflage is what they'll call it for men if we want to utilize it. So it
Oh
can
yeah, the
it can be
spray
done.
paint and like that, sure, for at least the purposes of film, especially that can be from afar, that can be some special effects. Well, I can tell you this much: I'll probably never go the way of Sam. Was it Sam Donaldson with the newscaster with the toupee that clearly was a toupee? Yeah. Well, we've hit a lot of areas. I'm going to leave you with last word. Any thoughts that you didn't get to express, or anything that you'd like to impart to potential patients, or anything else that you'd like to say?
No, I'd like to thank you. Thanks for having me. Thanks for even considering me to come on. Oh, yeah, there is one thing that I think just emerging, and I did think about it as far as feet. When I was doing my residency, the my chairman, he said the future of hand surgery is feet. And he's just like the future for all the people that are doing hand surgery. A lot of plastic surgeons do hand surgery. It's like the future of hand surgery is feet, and a very wise guy. Um, I've done one cosmetic foot case in my career,
Are you allowed to
and that
divulge,
was
or would it be oh,
oh
okay.
yeah,
Yeah, yeah, yeah.
yeah, it was separating toes. So somebody wanted to be able to wear toe rings, and their second and third toes were webbed. So when we do hand surgery and plastic surgery, and we treat congenital webbing in the hands, um, there's flaps and things that are developed for that. And so I did my one cosmetic foot case and separated webbed toes so that the patient could wear her toe ring. So that's my foot claim to fame. It worked eventually.
Nice. Well, listen, I've physically been by your facility to case it out. It's a wonderful, well-run organization. Externally, reminds me of those independent restaurants or medical facilities that that where there's lots of space, not so much in the Washington DC area, and it's nice to have a little bit more space where you are in Reston. If anybody wants to get in touch with you for consultation and or procedures, how would one find you?
Absolutely. You could always just go to the website for our practice, austin-weston.com, AUSTIN-WESTON. You could go to our Instagram, which is also going to be Austin Weston, make contact through there, or we actually have a real phone number, 703-893-6168. And if you search Dr. Poindexter in Reston, you'll eventually come up with me one of those ways.
That's awesome. Well, listen, this has been very illuminating, I think, for both the lay person and for physicians that aren't necessarily plastic surgeons. And I'm sure that, I guess, from the other side, there might be some connections that even a plastic surgeon might pick up a thing or two from this podcast. So thanks so much again for doing this. And we'll be looking down the road in Indiana for the next good thing to happen out there.
Go Hoosiers.
Yep, go Big Red.
I just want to say one word to you. Just one word.
Yes, sir.
Are you listening?
Yes, I am.
Plastics.
With hazy cosmic jive. There's a starman waiting in the sky. He'd like to come and meet us, but he thinks he